of showing white matter in the brain, and that is called Klingler's dissection. It's called a freezing the brain, and after that dissection is done. There's a standard protocol for that. I will come to that later. But there are no standard studies, especially how it goes in medical students currently in from the neuroanatomy education standpoint. Sections on the other way. This is a 3D fiber dissection. It's very complex to do. Talking about a way forward, we usually just as part of human language according to educational psychology. And coming to anatomy, which has a lot of spatial component, gestures has a lot of important role because it has a lot of role in embodied cognition and also in motor learning and motor memory. So these are some examples of focused gestures that are being used for evaluation. This is another area that I'm focusing on. So basically 3D fiber dissections, sections, and then gestures, and after that I'm focusing on virtual reality models. And I focused on two methods in which it can be modeling can be done modeling can be done for neuroanatomy education. One is called the mesh models that you are seeing here. So these are mesh models. If you see this is the brain stem and the spinal cord. So what do you mean by mesh model is basically if you compare to this image, you can see. I'm sorry, I have to show the mouse pointer for the online audience. So if you look at my mouse pointer, this is a golf ball, this is a scapula, and you can see dots over here. That is called a mesh. So creating a mesh is very important to create 3D models. 3D models are now very common. You have a lot of applications for anatomy education. So these are mesh models. So I use mesh models as well as, since it is white matter, we also focused on an imaging technique. It's called tractography. So this is a tractography visualization of two important white matter tracts in our brain. This is the I4 for the inferior frontooccipital fasciculus. This is the uncinate fasciculus. Can be very clearly visualized. So this is done from a human connectome project. Another area that I focused on, because we are using multiple methods, but how to know which is effective. So this I've used many methods to quantify which is effective for students. And one of the crux methods that I've used is cognitive load framework. Cognitive load framework says that there are any student who is learning has a lot of cognitive limitations. It's called the cognitive load, and there are factors which will aid our learning, which will hinder our learning. So these components are called intrinsic load, extrinsic load, and germane load. I'll come to that in the methods. So that is the cognitive load framework. So these are the basic structural framework that I use for my work. So coming to the research question is combining these in this way. Will alternative methods like sectional anatomy with hand gestures, so I'm not including one alone, I'm using sectional anatomy with hand gestures, or tractography based virtual reality models be effective in teaching and learning white matter anatomy as standard white fiber dissection, because standard white fiber dissection is considered as a gold standard. So I compared that with the other one, the other combination. Why I took that? Because standard white fiber dissection needs a lot of skill. I'll come to that in the methods. But the other ones are relatively similar to you. You take a section, you use hand gestures, or as technology is getting advanced, introducing tractography and virtual reality models may be more effective. So that is why we have that component over there, this component over there, and comparing with standard white fiber dissection. The hypothesis is that use of this sectional anatomy with hand gestures along with modern virtual reality models will be as effective as white fiber dissection. So that is my hypothesis. This is the objectives of study. As I said before, this is an extensive work which contains a lot of sub-studies. Putting all the content in a presentation is tedious, so I've put an orientation of an overview of the objectives here. So here I'm using this block for model development. Model development means I've used 3D models. Creation of the 3D models needed a lot of effort. So I've used it in two methods. One is segmentation, and the next is tractography. These are the two methods by which I created 3D models. One of work this was done partially with another project, which was a nationally funded project. In that, we have actually created the segmentation and tractography models. Then creating sections with the hand gesture framework. So that is another model that I developed, and also 3D fiber dissection specimen. This is the gold standard. So these three were one of my objectives. There is also a basic research component. Basically, I wanted to know whether gestures, I told you that we use gestures in our communication, but is gestures effective in anatomy teaching? So I needed to prove that also. So that is my basic research component. How much gestures is effective in spatial learning? And then some basic anatomy research, especially sections, has a role in understanding directional features of white matter. So for that, I've used some basic anatomy research as well. And all of them are converging into educational research. And this is where I use cognitive loads or qualitative feedback to understand whether it is effective or not. These are the primary objectives to develop these models. For 3D visualization, I used two models. One is stereoscopy and the next is monoscopy. Then I compared the effects of fiber dissection, simple sections, and hand gestures. I also used anatomy teachers' feedback, not only on students, but also I took a small sample of anatomy teachers and gained their perspectives also on the effectiveness and also the challenges of this. Secondary objectives, I worked on the utility of hand gestures and also to find the correlation between white fiber orientation and visual phenomena. Coming to the methodology, as I said before, it contains many methods, but basically one of the things that I've used is it's a multi-dimensional research design. Randomized control trials were used. There are two-limb randomized control trial for the use of gestures and a three-limb randomized control trial for comparing stereoscopy, monoscopy, that is called non-stereoscopy, and also conventional board drawings, because board drawings are one of the standard classical ways how anatomy is being taught. So I compared these three also with a three-limb randomized control trial. So I've used two randomized control trials. I've also done a workshop in which I compared these three, and I've also done quantitative and qualitative analysis. These are tools that I've used, pre-test and post-test examinations to students, so that I wanted to know whether the teaching was effective, whether learning has happened. For that I used pre-test and post-test, and also perceived cognitive load was also measured. Instructional skill, these are validated tools by which you can measure cognitive load and whether the instruction was effective or not. The setting was Government Medical College Trivandrum, Department of Anatomy for anatomical dissections and most of the studies, and Sri Chitra Institute in Trivandrum, where we worked for tractography models and virtual reality models, and stereoscopy compared with monoscopy was done there. We had an MOU, the Trivandrum Medical College, our department had an MOU with Sri Chitra Institute to do that testing. Coming to the methods that I mentioned, this is the traditional white fiber dissection. As you can see here, this process involves freezing the brain hemispheres at minus 20 degrees Celsius, and that is for a week. Then it is thawed in tap water for 12 hours. Then this is repeated, this whole cycle is repeated twice, and that is how we get this brain specimen. Why did we do that? Is because once we do this, then freezing and thawing will create water crystals, formalin and water crystals that will kind of naturally cleave planes between white fiber fascicles. After that, we can easily do a decortication. We can remove the cortex and we can peel out white matter fibers. We can understand their directions and peel it out. It's almost like how we peel out fibers in a muscle. It will be like that. So for that, we do this process. This is called the Klingler's method. Klingler's method was found in 1960s. So that's called stepwise dissection from lateral to medial and medial to lateral, and also inferior is also there. But lateral to medial and medial to lateral are the standard ones that is done. This is usually done for neurosurgery training. Neurosurgery fellowship trainings will have this white matter fiber dissection. So this is sectional anatomy that I've mentioned, and these are the hand gesture models that are combined with sectional models. So you can see how complex this one is. It needs a lot of skill. A skillful person with a lot of training only can do a reasonably well fiber dissection. But taking a section is very simpler, more accessible, and hand gestures are also can be easily used in our teaching environment. So that is the integration of the sectional anatomy with hand gestures. And next is virtual reality model. This is the mesh model. For example, we actually do segmentation. This process is called segmentation. For example, this is from the MRI data. This is sagittal MRI, this is coronal, this is axial. In that, we specifically mark areas. For example, this is pons, the basilar part, this is the tegmental part, this is the superior medullary medium. So we can segment each of the part in MRI. This is done as a tedious procedure. We actually manually draw it. This was done in Hyderabad, and we can mark different parts. For example, crus cerebri, tegmentum, tectum can all be marked, and a 3D model is created here. So this has a lot of time is spent on doing the segmentation. But once it is done, it can be used in any softwares. It can be given to students. It can be accessible in a 2D screen or in a stereoscopy method. And this is the tractography model that I've used. This subject is taken from the Human Connectome project. One random number generator subject was selected, and this is example. This is the corpus callosum. Corpus callosum we saw in sections it's different, but tractography gives you the three-dimensional appearance. So this is the whole part of the corpus callosum. This is the fossils, minor, major, the trapezial fibers. All this can be measured, and also sections can also be seen if it is in a. For example, this is a 3D PSI Studio software in which this was done. This is the methodology by which we compared the three models. This is stereoscopic projection. This unit was installed in Sri Chitra. So it's like we see 3D movies. We have a glass. So with the polarized glasses, students are all wearing polarized along with the instructor, and it's a darkened room, so we can't see the students or the instructor here. But it's projected on a silver screen, and you can see the structures three-dimensionally, and the instructor can rotate it, and it was done. So what I compared in this is a three-limb randomized control trial. You can see the three limbs: stereoscopy, monoscopy, and board drawings. This is the same instructor is teaching in stereoscopy room the same lesson. Monoscopy room is collaborative lecture hall where the same 3D model is not presented stereoscopically. It is not with a 3D glass. It is a well lighted room, but it's a 3D model which we have usually in our screens. So we compared these three. This is a okay, this is a I've taught the same brainstem content with board drawings here, which is one of the classic methods of teaching, and compared these three. So that is the three-limb randomized control trial that I've done. Then the effectiveness of 3D neural anatomy model for educators, that was done in 13 faculty members. And then studying the effectiveness of gestures in spatial anatomy, that was done in 94 mental students in two groups. This is a randomized control trial again, a two-limb group, gesture group and a non-gesture group. So that is how I studied the effectiveness of gestures. And finally, this is the final work that I've done, where I compared three models. For example, the fiber dissection model, the sectional anatomy with hand gesture model, and the tractography. So I've compared these three also, but this was not a trial. I just exposed these three methods to students and did a survey with that. So that is only 12 students in year two cohort that I've done this work. And these are the tools that I've used: assessment metrics, quantitative evaluation. There was pre-test and post-test scores. Post-test scores were divided into different components: basic recall, analytical type, diagram-based questions. And I've also done mental rotation test. Mental rotation test is each of us has a different spatial ability. Spatial ability is called spatial intelligence, or spatial ability is called our idea of understanding three-dimensionally complex structures. It is very, very variable for people. And those who have a difficulty in understanding three-dimensional structures, there are studies which have shown that they find anatomy very difficult. Okay, so they find it difficult to visualize things. So that is called, that inherent ability is called spatial ability. So spatial ability can be measured using psychometric tests. That's called mental rotation test by Vandenberg. So all these are validated tools. I use that. Perceived cognitive load was used. Instructional skills questionnaire. These are all validated tools which was used to measure students' spatial ability and also their cognitive loads, whether they can understand their cognitive load to understand the topic or not. Qualitative evaluations were also done. Surveys were done. Student feedback, open comments were taken. Likert surveys were done. Educator perspectives were also done using Likert survey. Quantitative analysis using Excel and SPSS. Qualitative analysis was done using RQDA. These are my results. For example, this is a fiber dissection. In my thesis, there's an entire sequence of pictures, but I've shown only a few. Here the cortex is removed, and you can see the subcortical U fibers. The cortex alone is dissected out. From the apex of the gyrus, you carve out and find the U fibers. So this is the subcortical U fibers that you get here. You can still see the lateral sulcus, the central sulcus. Then we remove each fiber layer. So the outer U fibers are removed, and into that here you are seeing the arcuate fasciculus, the right side, but on the left side is where you have the functional arcuate fasciculus. But you are seeing the different components. This will be the long segment. These are the short segments. This is the short segment. This is the inferior short segment. So different groups can be done, but these are done with a skillful dissection. It takes a lot of effort to do this. It takes hours to do layer by layer of dissection, and you have to actually remove one layer to find the next. So then the specimen will be destroyed. So it's a kind of a destructive process once we do it. There is a deeper layer in the, as you can see, this is the other side. So here you can see the uncinate fascicles, here you are seeing the inferior front occipital fascicles, the bow tie appearance of I4. So you are seeing all these. This is the medial side, you can see the corpus callosum here, you can see the cingulum, the different parts of cingulum. This is the frontal parietal segment, this is the long segment of cingulum, this you can see the fornix. So different parts can be meticulously dissected out. So that is the 3D fiber dissection that was used for the model. So these are the initial 3 groups of the model development that I have done. And the next coming to gestures, these are the studies that I have done on gestures. These are the results. I'm sorry. In this results, you can see the pre-test scores where you can see this relatively comparable. The p-value is not significant. In the post-test score, this is the control group. That means the deliberate use of gestures were not done here. This is the intervention group. And you can see the basic recall and applied knowledge has increased significantly. You can see the p-value here. So you can see significance in the post-test scores. And there's also cognitive loads are also better. You can see extrinsic load is the load that hinders learning. So extrinsic load is lower in the gesture group, and the germane load is higher in the gesture group. Both are important. Both shows that the learning is much more effective. The cognitive load is much more effective. So you can see the significance over here, and the effectiveness of the lecture was also done measured using instructional skills questionnaire, and the stimulation and explication is also found to be significant. This is also a significant part. The graph is a little complex, but it shows that this green segment is showing the significance. Okay, this axis is the mental rotation ability. As I told before, people have different spatial ability. So this is the spatial ability of students. This is the significance. This is showing how much significance it is having on students. So you can see over this area, it is showing significance in this much between these 2 dotted lines. The meaning of this complex graph is that students who have a moderate spatial ability or a lower spatial ability find it best when they see a teaching used with gestures. But if there is no gestures, so the students who have a moderate to lower spatial ability finds using gestures more effective in learning their anatomy. So that was the meaning of this graph. It's called Johnson-Neyman graph. And qualitative analysis were also used. This is the Likert scale where they have rated it high. These are also the comments that were found out by qualitative analysis. This was published in Anatomical Science Education. It was featured on the cover of Anatomical Science Education. That was a top-cited article in 2022. This is the sectional model that I have done. This is the midline sagittal sections. This is the axial section, and here you are seeing the tractography models that are created in the similar regions. And you can see the corpus callosum here. Here also you can see the corpus. You are seeing other fibers as well here, but here this corpus callosum and this fornix can be represented using gestures. Here you are seeing the right hand showing the corpus callosum. Here you are seeing the left hand showing the fornix. This is also there is something interesting also in these sections, because the fornix is having a little more whiter color, the corpus callosum is having a little more darker color. This is also a finding that was found in our study, and this is we are exploring the reasons to this. And the same phenomenon you can find in the internal capsule here. This is the posterior limb of internal capsule. It's having a darker color here. This is the anterior limb. It's having a fainter color. This is the tapetum and the inferior and the sagittal stratum and the optic radiation. There also you can see a color difference. I'm not sure whether it's appreciable. You can see a darker color here, it's a whiter color here. Both are white matter itself. So all these differences are visible on the tractography models, and it is visible on this gestures also. So this is something that we are, this paper is currently under review. So here again you can see the grey matter here, white matter here, and the white matter is having different shades. So this was also an output of our work. So this is showing the illumination which we used to capture this finding. You can see the different shades of white matter over here. And we did an extensive work on showing the same phenomenon in different brain models. And we measured the intensity. This is the measuring the intensity. If you look at over here, this is a violin plot. This is showing the cortex color. The y-axis is the color, the intensity of the color. And the intensity is less for the cortex. As you know, grey matter is called grey matter because the intensity is less. And this is the white matter, but within the white matter you can see different gradations of that white matter. And some regions, if you look at this graph, some regions the white matter can be darker than the grey matter itself. So this is the cortex color. You can see the color is lower. This is an artifact that is seen in formal and fixed specimen. This was also an output of our work. We correlated the image, and you can see the different colors in detail showing the fiber directions. And this was illustrated. The artist and one of our students has illustrated this using diagrams. This was presented in the Asia Pacific Conference in University of Otago, and this article is currently under review as an invited journal article and anatomical science education, neuroanatomy specialty. This was our 3D models that were created using segmentation, and this software is actually one of the outputs of the national funded research project, which was funded by SRB, Government of India. So this tool is called AnaView. So AnaView creates these segmentation models in the center and also radiological images on the side. And that was used to compare stereoscopic visualization with non-stereoscopic visualization. And again, we did a pre-test and post-test. And these are the post-test scores. And you can see significance for radiology-based questions as well as for basic recall. So these two found significance in these different domains in the post-test. In cognitive load also, you can see an enhanced germane load when stereoscopy was used and compared to the controls. S and C is for stereoscopy and control. This was published in BMC Medical Education and received a Kerala Chapter Anatomical Society of India award. And it was also part of a technical paper where the AnaView was presented in an IEEE conference. Again, these are the tractography models. There are two methods by which tractography models can be shown. This is sections again. So whole brain tractography can be done and sections can be taken, similar to the sections that we took in brain. And also specific white matter tract. For example, the corpus callosum that we mentioned here. This is the corpus callosum that we usually see when we do a midline cut. But this is the entire path showing the fossa major, minor, capital, and the body. So different parts can also be done using virtual dissection. So virtual dissection is also a possibility of teaching students the three-dimensional orientation. This was presented in, as a virtual poster in Anatomy Connected. This is the cingulum tract. This is cingulum tract containing the three different parts. The purple one is the long tract. These two are the short segments. And this is the IFOF and the ancillary fasciculus that I mentioned before. So these are two different methods by which a tractography can be visualized. Qualitative analysis, as I said before, gestures also done qualitative analysis, and also in the 3D models also I've done qualitative analysis. That was also published in National Journal of Clinical Anatomy. Then the results for analysis on this use in educators. So 14 anatomy teachers from Toronto Medical College were shown this tool, and they were asked to use it for teaching, and their feedback was also collected. And these are the results. The ability to teach on a Likert scale is rated 4+. Almost all of 4 and 3+ was shown in the qualitative analysis. That was also published again in National Journal of Clinical Anatomy. Student preference was taken on comparing the different teaching methods. For example, I compared the two models, which was my basic, the whole research question. I compared the 3D fiber dissection, which is the gold standard, and compared the sections of the brain, gestures, and tractography alone. So when I did these two comparison, they said that both should be combined. Mostly students prefer different methods to be combined, not a single method alone. So both should be combined was rated high. And when they were asked if only one option was given to them, why I asked this question was because we always have time constraints whenever we have a curriculum. And the thing that usually anatomy faces now is time constraint, because there is a lot of component, and undergraduate curriculum is getting shortened more and more. So if only one is given, which was opted, and their choice was sections of the brain and gestures more than 3D fiber dissection. More probably because fiber dissection is very complicated to do as well as to understand. So this was rated as more. And I did also a Likert comparison between the two. So this was the rating for the Klingler's dissection, and this is the rating for sections of the brain, gestures, and tractography. I actually gave the tractography models to students to play with, and as you know, students are really tech savvy. They can find these to be more appealing to learn white matter. So coming to the conclusion of my work, the research here has shown diverse methods of white matter demonstration and teaching. Quantitative analysis reveals teaching using novel visualization methods are highly effective compared to traditional teaching methods, especially in the recall domain. Addition of simple hand gestures to simple 2D sections has a high educational value. Not only the 3D, 5D sections, always gold standard may not be the only way, and there are other simpler ways that can be done. Creating spatial understanding has shown impact both in recall and analytical domain. Qualitative analysis shows merits, demerits, and critical review of various methods. Role of Klingler's dissection is also valuable to get a deeper clarity. So my understanding is that Klingler's dissection may be more suitable for advanced students, maybe further year students, or for further training after that may be more advantageous. Not for a basic undergraduate course. That may be an outcome of this. Another outcome of the research is the expression of white and dark shades of white matter. This was actually mentioned in the older books. Like the older manuals of Cunningham, not the current Cunningham, older manuals actually mentions this different color, but it is not recently mentioned in our literature. So that's we discovered that. We explained that along with in the light of detail and practical. So that is also an outcome of our project. And specific teaching methods to be used is best selected by understanding its merits and demerits. The study gives us the opportunity to be better informed about anatomical, traditional, as well as technological methods. This contains technological methods as well as traditional methods, and we should take an informed choice of which method we use to teach. And its interplay with the learner's cognitive process and how a teacher can modulate it. Recommendations and future studies. Beyond first and second year medical students, there is huge potential for this to teach advanced neuroanatomy to neurosurgical, neuroimaging, and neurology students. Incorporation of radiological anatomy into this model. For example, in anatomy, we have the 3 planes with MRI sections. So those are the things which teachers can use, as well as students can also play with it and understand how a 3D model will appear in a 2D section. Since a surgical setting, classical anatomical dissection may not be possible, virtual dissection experience for surgical trainees and fellows may be possible. That can be a further exploration of the work. And also, most of the works that I've done here are passive learning, like students are passively listening, but virtual dissection experience, if we can elaborate that, then we can give an active learning experience. Students can be asked to dissect out the corpus callosum from a virtual model. We don't have to, we don't need to spare a brain for that. So that exercise can be given to students. These are all study can be in further directions of the work. There is also a pressing need for orientation of faculty and demonstrators to be familiar with such a setting. The reason for the shade difference artifact, which I mentioned, seen in formal and fixed specimen. I did a pilot, I just compared with how it appears in forensic, in autopsy, but this phenomenon is not seen in non-formal and fixed specimen. So that needs to be explored further. And comparison of how this would appear in freshly cut postmortem brain specimens or in live surgical approaches to the brain needs more further exploration. These are my published work. The comparison between the stereoscopy, monoscopy, and board drawings were published in BMC Medical Education, in the Medical Education in India special issue. Then the teacher's perspective was published in National Journal of Clinical Anatomy. The role of gestures in anatomy, in spatial anatomy learning, was published in Anatomy Sciences Education, and it was awarded the cover feature. Then the student's perspectives, qualitative analysis of student perspectives, were also published in National Journal of Clinical Anatomy. One article is under review. It is an invited article, again in the Analytical Science Education, in the Neuroanatomy special issue. There were 3 oral presentations. 2 of them I did the presentation, the other one I was part of. That's a technical paper, showing the anatomy tool. And 2 poster presentations in Asia Pacific from EPICA conference in University of Ontario, and also in the anatomy conference. Thank you so much. these gestures has a potential role for anatomy teaching, because anatomy is basically three-dimensional. So conveying a lot of three-dimensional content with gestures is very useful. So that specific aspect of gesture is the one I have focused on. So if I'm talking like this, I'm using a gesture like this. That is called a beat gesture. So that is not the one that I'm focusing on. So in my intervention also, in that paper I've actually mentioned that I've defined that gesture. Like beat gestures are not included. So in my control group, that control group actually had beat gestures. Instead of teaching like with both hands in a robotic position, I use beat gestures as a control to make it, a meaningful intervention. So that is what I meant by this. So since students find difficult as gaze movements. So if you take the two eyeballs, like if I show the two eyeballs using two spherical models like this, and if this is the right eyeball, this is the left eyeball, I can show abduction of the right eyeball, adduction of the left eyeball. I can use my eyes also along with that. So this is a focused, a deliberate use of hand gestures for showing the rightward gaze or the leftward gaze. So if I add a muscle over here, like the lateral rectus, so here it's a very simple no cost method which I can use to show the abduction of the lateral rectus, to show, the contraction of the lateral rectus to show an abduction movement of the eyeball. So that's coming to the eyeball and the musculature. But if you add nerves, we can use our imaginations and to add maybe medial longital fasciculus, the oculomotor nucleus, abducens nucleus.
Basically, we have only used our fingers to move this way.
Yeah.
So it's very novel.
Thank you.
I'm Dr. Jayaprasad from Japan. I'm an ophthalmologist in private practice and then also a DNP trainer. For me, learning neurology is very difficult, neuroophthalmology particularly, and neuroanatomy related to neuroophthalmology is even more difficult. And at 63, I have less of cognitive abilities. So 2 years back, I went to write my FRCS exam. So I was searching for some source, some material from which I can pick up neuroanatomy and neuroophthalmology. And I hit upon Dr. Doris's air anatomy, where he uses his hands to really teach us the anatomy of the medial longitudinal fasciculus, internuclear ophthalmoplegia, extraocular movements, and its defects. Everything was there online actually, his videos, and excellent videos, and it's really beneficial, I feel, for postgraduate students in ophthalmology too, to learn about all these basics related of neuroanatomy related to ophthalmology. Thank you, Dr.
The DTI, there were actually two sources. For example, I'll take the methods. Yeah, the tractography models was from Human Connectome project. Human Connectome project is publicly available. So that was one which we used tractography because to get the finer or detailed high resolution view of a tractogram, we need a lot of parameter differences, high p-value were all needed, multiple directions were needed. So that was available best on tractography, the Connectome project. So that is one source that we used. That's a single one, and the other is was this for the segmentation. We actually used one volunteer that was part of that DST funded project. That's a single volunteer. So there's two individual subjects. One for DTI based imaging, for example, the one that I used for capitum, and that was from that volunteer. I mean, the volunteer.
Just a question out of curiosity. When you do a 35-year-old male radiology investigation and you compare specimens with the cadaver, that is probably more than 65 years.
Yes.
So what's the take on your middle-aged DTI image with the conventional teaching using a brain of 65-year-old?
We didn't actually explore that with a proper study. Like we didn't do a complete. There was more of an exploratory work currently about that shades, but we repeated that in multiple brain specimens, and we found that consistently in one, especially the lateral trigonal area. We found that consistently there, and also places where you have contrasting fiber direction. For example, inferior and anterior posterior. So it's a complete contrasting direction. There we are seeing the shape differences. But as you said, age and I have not explored that properly.
There will be some amount of
That is, yes, and also myelination in different ages, that should also be considered.
Regarding the virtual reality, the stereoscopic 3D image was the mode. I mean, that's not per se virtual reality.
That is not per se virtual reality. Actually, when the title was framed, we used it as virtual reality. If we go to the specific technical term, it's not ideally virtual reality because that needs a VR headset. But this is more stereoscopy, and virtual models would have been a better term.
And the assessment part, what are the category of questions? Like it was diagrammatic?
It contains basic recall, analytical questions, image-based questions, and diagram-based questions. Because these are usually, according to Bloom's taxonomy, we assess the lower ones or the higher ones. And imaging also frequently being asked, especially further year questions. So that's why we made it into 4 domains. Thank you. The queries and comments by 3 external examiners of the evaluation of thesis. Examiner 1, these are the comments. Development of an MU contributes to advancing teaching of neuroanatomy not only to MBA students but also neurology, neurosurgical and radiology students. Accepted. And for YOC, examiner 2, role of transistors, an effective and accessible method can be popularized. Limitations of modern techniques like cost, need of training and technical limitations if overcome is very successful. Accepted for open form. Examiner 3, commendable work, accepted for open defense with clarifications to be obtained. And there are queries. One is how cognitive load domains were operationalized and validated across interventions. The tool that I used is published by Pink et al. Famous paper published in 2013. It contains a series of questions which measures the intrinsic load, extrinsic load, and germane load. When we read the questions, we won't understand whether it is measuring a load or not, but it was validated, and that was the one that I used both in the 2 RCTs, both in the gesture versus non-gesture RCT and also the 3-limb RCT. In these 2, I've used the Pink et al. Tool in those 2 interventions. In the workshop that I've done, where I compared the gesture group, the 3D fiber dissection and the sectional method, there I didn't do a trial, so I didn't use the cognitive load. I used cognitive load too early for these 2 randomized control trials. And the next question was, what were the major confounders expected during student grouping? How were biases addressed during student grouping and qualitative feedback analysis? The confounders that I think is student academic performance, that can be also gender, spatial ability, that confounders. And what I did is pre-test score comparison was what I did to compare the different groups. Randomization was done for both the interventions. So those 2 the randomization should make it homogeneous, make the groups homogeneous. I didn't do any like student grouping, A batch, B batch. I didn't do anything like that. I did only randomization to make it homogeneous. Also, I did an additional pre-test comparison. Pre-test scores were compared. In one, I also compared their part completion test scores. Their average sessional exam marks were also compared, and I found them to be non-significant. So they are comparable. So these are the things that I've used. I've addressed to make it homogeneous and avoid the biases. The third question was whether the aeroanatomy gestures. By the way, the term aeroanatomy is the one that I use for that deliberate hand gestures. Not just the regular gestures that we use, but the deliberate hand gestures used for anatomy teaching. Focus on that is what I call the anatomy gestures. Be standardized and disseminated for wider use in other anatomical areas, and whether VR models can be incorporated for routine academic use in low resource settings. For the first thing, I didn't do any standardized methods, but there are popular gestural methods which anatomists usually use. For example, the scapular spaces. It's kind of internationally acclaimed. Everyone will use that, or the greater tubercle sit. There are gestures like that which are standardized, but I didn't attempt for that. But one that I found which actually cited one of our works was Graven website. This was actually a neurosurgical training website where they use gestures. I forgot the expansion of Graven. G is for gestures. So they create gestures like this to show neurosurgical approaches. Or here they are showing the. I can zoom in. showing the A3 and A2 here, and we are communicating with the gesture. And this is a specific neurosurgical approach and neurosurgical window where they can identify these structures using this gesture. And this website was developed in China, and they say that they are trying to create a standardized set like that. I didn't attempt that till now, but maybe because that may be a good method to make teaching and learning effective. So this is a neurosurgical source. And the next is whether VR models can be incorporated in routine academic use. Stereoscopic portable units for visualization is being developed. It's a kind of a continuation of that project. Currently, it's done by a startup. So that was one of the outcomes. And then fourth, whether long-term memory and understanding of neuroanatomy concepts were attempted. That is one area that I didn't attempt. That is the most significant one, but most important. But due to practical reasons, I didn't include that in my study. But obviously, that is the most important thing, whether long-term learning is happening or not. But that may be more complicated. Be difficult to. These are the questions.
So, sir, now I can request the external examiner to further it. Can I? Yes. That will be.
Yeah, I just wanted to make a statement. It's my pleasure that we have you, professor from CNC. I was trained in neuroanatomy in 1984 by Professor Naidu. So it's my pleasure to have you here. And the research. And a few comments. I don't know whether training in neuroanatomy has changed over the last 40 years. Because listening to you, it seems that there is tremendous opportunity to comprehend brain much better neuroanatomically. It's very important that all of us, I took a theory exam in neuroanatomy and then a practical exam where Professor Mary Jacob and a neurosurgeon from Chennai. Those days we had first year exam for PPM and ND. So there may be some implications for assisted living. For example, if I am into my 80s, I am frail, I have sensory issues, and then lots of instructions for non-pharmacological interventions may be better trained using widely acceptable gestures or whatever. Maybe we will need an agreement on that. Everybody should comprehend these gestures and other methods, non-verbal, in a similar manner. Maybe, I don't know whether sign language has a universally accepted gesture or whatever. So I think
it's culturally different. Because Norwegians don't.
Yeah, culturally different. Actually, in the international scenario, that's also a point.
Yeah, I think having worked with people with dementia for the last 25 years, it's always an accompaniment. You try to figure out between the caregiver. I'm also a caregiver myself who looks after my mother. So you work out a lot of things, and then even a failing dysfunctional brain probably can take a method of communication which is non-verbal. If it is repeated, and then between you two, you know what it means, and that kind of a communication can develop. So thank you very much for that. We look forward to future collaboration. I urge on behalf of the Office of the Dean Research, please take it up with medical education and neurosciences. We will be very happy to help.
Result and declare if he has successfully defended the thesis and completed his PhD.
I congratulate Dr. Doris for this excellent presentation, and he's been declared his PhD. Dr. George Yohannan, Dr. Hazel Das, and Dr. Rumesh, who made them for result and complete his project. So congratulations to the guys as well as to the candidates.
Almost seven.
One second. So 1 second.
അല്ലാതെ സാറിന്റെ ഇതിലാണ് പ്രശ്നം. ബാക്കിയെല്ലാം കേൾക്കാം. സാറിന്റെ ഇതിലാണ് പ്രശ്നം. മൈക്രോഫോൺ എടുത്തിട്ടില്ല. ആ പോയി വീണ്ടും പോയി. തോമസ് സാറ് വീണ്ടും പോയി.
സാറ് കേൾക്കുന്നില്ല സാർ.
സാറൊരു കാര്യം ചെയ്യും, ഒരു ഹെഡ്ഫോൺ വെച്ചിട്ട് സംസാരിച്ചോളൂ. മറ്റേ മൊബൈൽ ഹെഡ്ഫോണോ വെച്ചിട്ട് മറ്റേ കാണിക്കുന്നില്ല. പിന്നെ പോയി. എന്തോ ഒരു കണക്ഷൻ ഇഷ്യൂ ആണത്. ഇടയ്ക്ക് വന്നു.
Thank you, sir. Thompson, sir, Yohannan, sir. Thank you very much for permitting me this external link. I am working up to an open art surgery. Doris, I know him for the last 2 decades. He is very consistent with whatever he does. അങ്ങനെ എന്ത് കാര്യത്തിൻ്റെയും അങ്ങനെ അറ്റത്തെ ഡെപ്തിൽ പോയി എക്സ്പ്ലോർ ചെയ്ത് എക്സ്പെരിമെന്റ് ചെയ്യാനുള്ള ഒരു ടെൻഡൻസി ഹാസ് ബീൻ ഷോയിങ് ഫ്രം വെരി ഏർലി ടീനേജ് ഗ്രൂപ്പ്. അതിപ്പോഴും മെയിൻറ്റെയിൻ ചെയ്യുന്നുണ്ട്. വിഷ് ഹിം ഓൾ ദ സക്സസ് എവരിവെയർ ഹി ഗോസ്. ഈ റിസർച്ചും റൂട്ടീൻ വർക്കിനെ ഒട്ടും അഫക്ട് ചെയ്യാതെ ആഫ്റ്റർ 4 o'clock he used to stay in the department till 7:30 in the evening. I used to be with him for the dissection. അങ്ങനെ ഭയങ്കര ബുദ്ധിമുട്ടി ഒരുപാട് ഹാർഡ് വർക്ക് ചെയ്തിട്ട് ഉള്ള ഒരു പ്രോഡക്റ്റാണ്. പിന്നെ കേശവദാസ് സാറിൻ്റെയും തോമസ് സാറിൻ്റെയും അകമഴിഞ്ഞ അഡ്വൈസും പ്രോത്സാഹനവും ഇതിന് കിട്ടിയിട്ടുണ്ട്. ഫ്രം എവരിവെയർ many sources he has been promoted for this research, and this is I am very happy to enjoy the presenting session of this hard work lasting 5 years. Wish him all success. Thank you all. Thank you.
ലോഗിൻ ചെയ്താൽ മതി, പ്രശ്നം തീർന്നു.
Okay. I think the occasion, I'm sure all of you will observe and feel the mentorship in action here. My very senior professor.
പറഞ്ഞതുപോലെ ഡോറിന് വളരെ മെറ്റിക്കുലസായിട്ടാണ് കാര്യങ്ങൾ ചെയ്തുകൊണ്ടിരിക്കുന്നത്. അതിൻ്റെ ഒരു ഫൈനൽ പ്രോഡക്റ്റ് മോഷൻ മെറ്റിക്കുലർ വർക്ക്. ഐ പേഷ്യൻ ഓൾ സക്സസ്.
Thank you, Tom. At the moment.
I thank Thomas sir and Umesh sir. In spite of their health condition, they could join us today and give their comments. Also, Harikumar Nair sir and all the senior members, senior faculty members from various institutions who have come here. Thank you very much. There is no doubt that he deserves PhD. It was so good. So my only request is because at present he is in UK and I am missing him. So he is doing such a wonderful job. If he was here, we could have continued to work, and one day he will be back and we will start again. Thank you.